Thank you to all the faculty of the New York Transcatheter Valve Symposium. My name is Michael Cryer. From Columbia, South Carolina. I was lucky and grateful to do my interventional training last year here at Mount Sinai, and currently a structural fellow in Tucson at Tucson Medical Center. So it's an honor to be in the room with such cardiovascular giants, so thank you. Let's see, there we go. I have no disclosures. So we'll go on with the case. This is a 76-year-old, a Caucasian male, who presented with 4 days, fatigue, shortness of breath, on and off chest pain. He presented to an urgent care where he was evaluated and felt appropriate for discharge. On the way to his car, he had a near syncopal episode, and EMS had to evaluate him, and upon evaluation decided to bring him to our center at TMC. He was noted to be hypotensive, was given fluids, blood pressure improved with normal saline. He doesn't have much of a medical history, hypertension, hyperlipidemia. He's a very active golfer in the community, knows a lot of the local pros and stuff. So his EKG on presentation to our emergency department showed this, anterior lateral MI and sinus rhythm. Vitals, borderline hypotensive, not bad, 100/72, 85 heart rate if febrile, satting well. Troponin of 2.7, this actually remained relatively flat, fluctuated I think around 3, but this is the initial set of labs. He had also an acute kidney injury, creatinine at 2.8. So we brought him to the lab for an emergent left heart catheterization, and here, this is his initial angiogram. Here you can see an LPL1 that is occluded. I did not include the RCA, it was not obstructive. And then an 80% distal LAD disease here. His EDP was 28, and his blood pressure had trended down at this point. He was 85/55 and requiring norepinephrine and dobutamine to maintain this blood pressure. In the back of my head was Dr. Kinney saying we need an echo, so I decided let's go ahead and get our echocardiographer in the room, and just to make sure there was no large LV thrombus or any mechanical abnormalities. And at that time, with the point of care ultrasound we performed, the F was about 25%, no evidence of LV thrombus, and what we felt like at the time was moderate MR. So we proceeded with PCI, here indication for such, and ACS. We also elected for an Impella CP given the ongoing shock despite 2 inotropes. We did Impella CP with single access, 7 French EBU, 3.75 guide, pilot 50 wire, and did a 312 NC emerge for pre-dilatation of this lesion. And then this is after pre-dilatation. And then we proceeded to stent with a 3038 Synergy with post-dilatation of a 312 NC balloon. And this is after that. So blood pressure hadn't improved tremendously. We turned our attention to the LAD, feeling like, patient ongoing shock, that we should give him, better flow down to the apex of the left ventricle, pre-dilated, and then treated with a 2.5/24 Promus Elite drug-eluting stent. We elected to avoid getting involved with the diagonal and got a relatively decent result there. Here's our final image. So still a little sluggish flow down the LPL. We had given Cardine, and part of that was probably, we felt at the time, the elevated LVEDP with low blood pressure. So the next morning, we left the Impella CP in place. We had noticed that his urine output was still poor. He was still requiring the inotropic medication, and the Impella we couldn't wean below P7. I generally try not to keep the Impella above P7 just because of increased hemolysis, but trying to wean it below that, he would tank. So this prompted us to further evaluate what was going on with his cardiovascular status, and we reviewed the echo from that day. We get daily echoes with the Impellas in place, and felt like his MR was quite prominent and a little concerning. So we set him up for a TEE, and here we see that the papillary muscle head is actually avulsed, and you can see that there's papillary muscle rupture with severe mitral regurgitation and a flail segment. And you can see he's got a ERO or a PISA that's massive. I forget his ERO is, I think, over 1, but his TE here. We had an urgent heart team discussion. Given his shock presentation, his STS was extremely high, felt like prohibitive for surgery. He was on P2Y12 medication for the recent PCI, and based on the anatomy, felt appropriate for a mitral transcatheter edge-to-edge repair. There's concern for the coaptation gap. We've been fortunate in our center to be able to tackle some of these large coaptation gaps. I think we've done as much as 2.1 centimeters and got a good result with the G4 and independent grasping. That's been it's been possible. Not every case, but it's certainly achievable. Indication here, prohibitive risk for surgery. So this is, there's not terribly much to show with the procedure. It probably took about an hour. We were fortunate. We had a 1 XTW, pretty much nailed the flails, what we say, and got a really great result at the time. We didn't have to do independent grasping in this case. We're fortunate to get away with the traditional methods. So you can see, I don't know if it's quite evident, but we trapped part of the papillary muscle head next to the clip. And that's great for the day of the procedure, and we got residual 1+ MR, but I think a teaching point or something to be aware of in these sort of cases, and I've spoken to a couple of other operators who have taken these cases on, they've had anecdotally some of these experiences as well. Over time, what can happen is the papillary muscle head can start to necrose, and there's withering away of the tissue, atrophy, and the MR can actually get worse. It can change the anatomy and the way the clip is interacting with the leaflet. And we were happy, we got him through this index hospitalization. He, you can see normal PV flow. He's blunted before, good gradients. Went home with an EF of 45%. He was in the hospital for 13 days and not great for him, but a funny story is he's probably delayed about 3 or 4 days because he was on anticoagulation and they were trying to get an IV in his left arm. And they hit his artery and he ended up having a massive hematoma and had to get actually fasciotomy of the left forearm for that. The vascular surgeon was actually, he kept writing in his note, this is from the left radial access, and we'd never stuck the left radial, so we actually had to go back and, we talked it through. The patient did fine with that. We saw him in follow-up a month later, and that atrophy of that papillary muscle head had kind of reared itself, its ugly head, if you will. And he had New York Heart Association Class 3 symptoms, redevelopment of these symptoms, and his transthoracic echocardiogram showed, severe mitral regurgitation. So we sent him for an elective surgical bioprosthetic mitral valve. There's a quick, there's not a lot of literature right now. It seems like most centers are starting to have experience with these cardiogenic shock Impella cases with M-TEER, but this is what exists in the literature so far in terms of a case review, retrospective case review. Most of these actually were not ACS cases, and they were chronic heart failure in cardiogenic shock, but they were extremely sick patients. A lot of them were on mechanical ventilatory support. And you can see most of them did well. I think 5 out of the 6 cases were a success. Fortunately, one was not. But in follow-up, the patients that were a success were doing relatively well. So this is, shows that there's some feasibility to this. And we await further registries and further information that may come of these patients. I will say, as a question I have gotten about this case is, did the Impella interact with our ability to perform the procedure at all? And from our experience in talking with other individuals, it really did not. We did not interact with the Impella at all. That's all I have.
Are there quick questions? We have 1 minute. Greg, it's a STEMI case.
Yeah, great case. Just a minor point. I would not have done the LAD. You've got a patient in shock. We have the culprit shock trial, which has showed that worsens outcomes, especially when you start with a patient with creatinine 2.8. But it didn't
That's
hurt.
fair. Right?
So the papillary muscle, it's on. You said the right coronary was patent, right?
Yeah. Well,
So that's unusual to have a papillary muscle rupture with just a circumflex occlusion. It was a big circumflex,
Right.
And again. Do you think that the papillary muscle head that you trapped was a different papillary muscle head than the one that ruptured? Because it was already ruptured, it was already necrosed. So I'm wondering, did you catch a different papillary muscle head, which led to the severe MR recurrence? And was there any thought to possibly putting in another clip to try to treat the MR at that point rather than send the patient to surgery?
Right. I think we caught the papillary muscle head that ruptured. I think it would be hard to grab the one that hadn't. And then,
Worse.
sorry?
Why Did the MR get worse if that head was already ruptured?
Well, I think, the muscle head, when we trapped it, had probably, been dead, if you will, for lack of a better way of stating it, for a couple days, and as time goes on, that muscle would necrose and shrink in size, I think. Does that seem reasonable, or does that, no?
So the reason is that, see, all that you can trap is the leaflets and the papillary muscle, right? That's dead. It doesn't matter. Basically, the reason why you have severe MR is loss of chordal support to the mitral valve, right?
Sure.
And what happens is that you have loss of primary chords and secondary chords. And so what happens is when you put the clip in temporarily, the other secondary chords from the other we can just break up. That's why it never lasts. I've seen all my cases that I've done is they do well initially, but then because you got normally degenerative MR, you lose primary chords, but the secondary chords are intact. When you lose the papillary muscle head, you lose the primary and secondary chords for that entire segment. So there's no support to that leaflet. So it often either gives away or you have.
Yeah. Sure, yeah.
Well, that was
Yeah,
a
we don't.
fantastic case. Thank you so much. Great questions. Please